I start.
Yes,
Hello, good afternoon, doctors. On behalf of Heathrow, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors, we know that at Heathrow Healthcare, we've got 25 years of excellence, 36 state-of-art manufacturing facilities. We have got 300 plus products in our portfolio with 21,000 employees globally. Our presence, we are present in 126 plus countries, and we are amongst the largest manufacturers of ARV, API, and FDFs in the country. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. At Heathrow Healthcare, we are 360-degree solution provider. We strive to fulfill unmet healthcare needs. We reach out to customers across India. We have a wide product range encompassing multiple specialties and pioneering in quality and innovation. We have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Carbetocin, we know, is a drug used for prophylactic management of postpartum hemorrhage, and postpartum hemorrhage is a potentially dangerous condition which can lead to disaster. Although there are many studies and publications on the role of carbetocin in PPH, we would like to have our own doctor's opinion and experience on use of carbetocin in action. For that, we have got Dr. Dinesh Bagul today with us. Welcome, sir. Dr. Dinesh Bagul is MBBS, MS, FMAS. Sir is in addition to diploma in endoscopy. Sir is chief consultant at Bagul Nursing Home, Nasik, affiliated to visiting laparoscopic surgeon and vaginal surgeon at Ashoka Medicover, HCG Manvata, MS Hospital, Suman Lilavati, Nashik. Special interest in vaginal surgeries and fertility sparing laparoscopic surgery. Sir was faculty at International Endoscopy Conference, Nepal 2024, paper presentation at AMOGS 2012, video presentation at Laparoscopic Conference, Pune. Welcome, Dr. Bagul. Welcome for your experience on Carbetocin. Welcome, sir.
Thank you. Thank you for nice introduction. And good afternoon, everyone. And as you know, today's topic is carbetocin overview or a postpartum hemorrhage. Next. See, as we know, what is a postpartum hemorrhage? It is one of the most commonest cause of mortality and morbidity in all antenatal women or pregnant women all over India and all over world also. So PPH is in normal delivery when there is a blood loss of 500 ml or more than that, and in cesarean section more than 1000 ml. So that called PPH, and it is, as I already discussed, it causes many maternal losses also and morbidity also in our developing countries. Next. So we know the postpartum hemorrhage, it's unfortunate, yet common. So maternal mortality is accounting around 35% in all maternal deaths. So it is due to the PPH. Also the maternal mortality ratio, that is MMR. In developing countries like India, we have 240 in per 1 lakh live births compared to 16 in the developing countries. And what is the global scenario? In global, there are almost 14 million women suffer from PPH, and incidence of PPH is reported to be around 2 to 4% after normal delivery and 6% after C-section. So what is the incidence in India? Around 38% of maternal deaths are due to PPH, and 25.7% of global deaths take place in India, and 2/3 of these attributed to the PPH. So you can see the scenario in India, around 540 per 1 lakh live births we amongst the maternal death due to PPH. Next. So what is the etiology of postpartum hemorrhage? So as you know, there are four T, that is tone, thrombin, trauma, and tissue. What is meant by tone? When the delivery happens, the uterus should get proper contracted and retracted. But when there is no tone, that is inability to contract the uterus after delivery, it may lead to the PPH or continuous PV bleeding. Thrombin. The thrombin means that is a defect in coagulation factors. When there is a associated high-risk pregnancy like a severe preeclampsia, eclampsia, abruption, or there is any medical disorder causing liver failure or liver to produce clotting factors, then it will lead to the DIC, and that leads to the PPH. Next will be the trauma. Trauma, which is whatever trauma I do to the cervical region, vaginal region, uterine rupture or uterine inversion, lacerations, all this attributed to the PPH. That is called traumatic PPH. And tissue. When there is a retention of any tissue, tissue means what? Any placental tissue, blood clots, or abnormal membranes, or any abnormal placenta which is retained inside the uterus, that will lead to the bleeding. And that these are the commonest causes of PPH. Next. So what is the clinical findings in PPH? So as we know, what happens in PPH, there will be a patient will complain about the uterine abdominal pain, there will be tenderness, there will be circulatory collapse. What is meant by circulatory collapse? There will be a hemodynamic changes, patient will have tachycardia, hypotension, sweating. These are the circulatory collapse. Then there will be increasing in abdominal girth due to the increase in size of the uterus due to clots. There will be loss of uterine contraction, uterus will be flabby or soft uterus. There will be tachycardia and active vaginal bleeding. So as we know, there are the 4 degrees for the PPH and degrees of the shock caused by the PPH. First is the compensatory phase, then there will be mild PPH, then there will be moderate and severe. What is meant by compensatory phase? That is blood loss of around 500 ml to 1000 ml, that around 10 to 15%, that will be compensated, that will be tolerable by mother. There will be no any hemodynamic changes, there will be no any tachycardia or blood pressure changes, but there will be little bit symptoms like patient will feel palpitation, like little bit dizziness. But when there is a mild PPH or mild shock, then their blood loss will be around 1000 to 1500 ml. That attributes to 15 to 25%. Then there will be little bit hemodynamic changes. We can see there will be fall in the BP. Around systolic BP is around 80 to 100, diastolic maybe around 50, 60. So that leads to the symptoms. Then patient will have minor symptoms along with this, like weakness, sweating, tachycardia, hypotension we can appreciate. Moderate PPH is around 1500 to 2000 ml. There will be marked fall in the BP. BP will be around 70 to 80 millimeter of mercury. Patient will be restless. There will be appreciable pallor over the conjunctiva or the tongue. There will be oliguria. These are the signs of shock, moderate shock. And when there will be a severe PPH, that is blood loss around 2000 to 3000 ml, then patient will have false mark profiles fall in BP. Patient will be in shock. Directly, patient will have 50, 40 hypotension, systolic BP. Patient will collapse, where hunger will be there, breathing difficulty will be there. Patient will end up in the anuria or renal failure. Next. So this is the types of shock due to PPH, and now how we will diagnose the postpartum hemorrhage. See, there will be three methods of evaluation. First will be our initial evaluation, our clinical judgment. Then there will be a examination of the patient, and there will be laboratory assessment. What we'll see in the initial evaluation, we'll assess the patient status. We'll take that, we'll notice the any tachycardia will be there or any hypotension will be there. We'll see the vital signs, and there will be assessment of the blood loss. Depending upon the severity of blood loss, we can judge the type of shock, whether patient is in mild shock, moderate shock, or severe. Then there will be next will be the assessment, the examination of the patient. So we'll assess the genital tract for any laceration. We'll rule out the three things. Either we'll see for the atony, is there any atonicity of the uterus. Then we'll assess for the any tear, laceration, hematomas, or any signs of uterine rupture. We'll do the bimanual examination. We'll see for the any retained placental beads, any membranes will be there inside. Then we'll try to remove that. Also, if there is no any other findings we are getting, then we can do bedside ultrasound. So we can see whether uterus is contracted. We can see the blood clots in the uterus, or if any problem is there, we can see the rupture also. And also see for the uterine inversion. It is rare, but we can see due to inversion, there will be profound PPH. And next will be, as we know, there will be lab assessment. We should do a complete blood count, that is CBC, hematocrit, and platelet. And also, if we have to rule out any thrombin disorder, then we have to do coagulation studies, that is PT, INR, APTT, and BTCT also. Next. So this was the initial evaluation PPH. Now approach, what we will do in the, as a doctor, what we do towards the when patient lands up in PPH. So we as already know there will be a 4 types of problem. There when we see the tone, that is if there is a poor uterine tone, then findings will be uterus will be flabby, uterus will be soft. Then we can do we can feel the uterus, that is fundal height will be increased. The fundus may be filled above the umbilicus due to the blood and clots inside the uterus. Then in such cases, we'll do the CBC count, coagulation, other LFT, KFTs. Sometimes we do electrolytes also. If we feel there will something rupture inside, then we can do bedside ultrasound. How will you manage the atonic PPH? First will be the uterotonic agents. As we know, there will be several uterotonic agents, that is oxytocins, prostaglandins, ergoid alkaloids. If it is not controlled with uterotonic agent, then we have to do a minimal surgical exercise like a uterine balloon tamponade. And if still there is any major still bleeding is there, then we have to take patient into the operation theater. Then we have to do laparotomy, surgical measures, step for devascularizations, and sometimes patient may land up in the obstetric hysterectomy. So this is the case in the cases of atonic uterus. Now, when we see the tears or trauma, as we know, tear may be at any level, either uterine tear, cervical tear, or vaginal tear. Then we have to look for the bleeding from under proper per speculum examination. Either we have to shift the patient into operation theater, give a proper anesthesia, and we can examine from below. So we have to assess the everything from vaginal tract to cervical region, and we can see for the any tear when it is a normal liver, and one already it is in the patient is undergoing LACS, then we can assess on table if there is an extension of any uterine angles, or if there is extension of posterior wall of the uterus, or if there is rupture, then we have to suture it and we can manage on table. So there will be 2 scenarios when patient will be in labor, normal delivery, and in the LACS. And then in rarest of rare possibility, there will be another causes like there will be rupture of subcapsular liver capsule. If there is rupture of any ovarian vessels or splenic vessels, then we have to assess, or we can take the help of general surgeon to assess the upper abdomen. Same investigations, direct what we do in the LACS, we inspect everything, direct extrude the uterus and see any abnormal bleeding. And if anything needed, we can do ultrasound also for the upper abdomen. Management will be the repair, as we already discussed, we have to repair whatever tear is there. And in the rarest of rare cases, we have to do sometimes arterial embolization to stop the blood supply of that particular organ. And next will be the retained tissue. As we know, if there is any retained placenta membranes, then we have to identify it with the examination, bimanual examination. We can do examination or MRP under general anesthesia, or we can do spinal anesthesia. General will be better. And we have to remove the placenta or return bits of placenta in OT with proper uterotonic supports also, and proper resuscitation. Okay. This is the management of retained tissue. Retained tissue is a little bit easy, as we can easily identify it. And next will be coagulation. It is one of the nightmare when patient is in DIC, that is disseminated intravascular coagulation. Then there will be profuse bleeding, continued bleeding, uterus will be contracted, but still edges will be bleeding. Then that is a nightmare. Then we have to manage everything. We have to do investigations, urgent basis like CBC, coagulation profile. We have to see prothrombin time, blood clotting time, APTT time, and then according to that we have to manage this patient. So we need a special blood products, plasma, or sometimes platelet also. So we have to resuscitate patient with all these products. And then if there is any, along with that also, if there is surgical issue, then we have to correct with our surgical problem. So these are the management of approach towards the PPH. Next. So what is the rationale for development of carbetocin, and what is a new heat stable formulation? So already what we discussed in previous slide, what is the PPH and causes of PPH. Now when we look for the management, the first management or formulation will be oxytocins. So oxytocin, what is meant by oxytocin? There are two different. Now previously one only we have oxytocin. Now second derivative we launched recently, that is a carbetocin, which is available at room temperature and which is stable formulation. So what is the difference between oxytocin and this carbetocin? That is first most is the refrigeration. Means the oxytocin will require 2 to 8 degree temperature for its maintenance and its full activity, while this carbetocin will be active and it's good at the room temperature also. So it has a shelf half-life of 24 months at 30 degrees Celsius, but the oxytocin will degrade immediately when it will be in the open air in the room temperature. Also, there will be lots of issue with the cold chain monitoring when we carry the oxytocin. And also, like a country like India, where in the rural setup there will be a lack of cold chain transport or there will be lack of electricity, then there will be issue with the oxytocin and the potency of the oxytocin will be less. So with the new heat stable formulation, carbetocin now available in the market and we are using thoroughly. Next. So use of uterotonic agent. So what are the uterotonics we have available? When we see there are multiple, as traditionally we using oxytocin, the next derivative is carbetocin, as we know ergometrin or methargine. The symptometrin is there, that is a combination of ergometrin along with oxytocin and the misoprostol tablets. So there are different modes of administration. Sometimes we go at the level of crowning of the baby's head, sometimes after delivery of the anterior shoulder, majority of the time at the end of second stage of the labor, and sometimes in the following of the following delivery of the placenta. Routinely, we use the this oxytocin or these uterotonics for prevention of PPH or sometimes at the active management of the third stage of labor. And therapeutic use, when there will be a PPH, then we have to use combination of these uterotonics. Next. So carbetocin, as this is the this is a formulation of this next generation PPH management molecule. That is as we know, that is a synthetic analog. Next, sir. Next. So these there are multiple trials under this carbetocin has already gone, and compared with the oxytocin, it is a when we compare with oxytocin, it is effective and also it hits stable, so it is best in the management of PPH. Carbetocin is non-inferior to oxytocin. Already WHO, this trial is undergone and they assess this. There are almost equal or comparable efficacy of carbetocin with the oxytocin. Next. Also, there is a Cochrane review. There are 2635 women are already underwent this study, and they have seen the carbetocin and oxytocin are comparable, or carbetocin will be more effective in the management of PPH. Next. So there are guidelines. There are different these societies: American Society, Canadian Society, New Zealand, FIGO, or WHO. Already I given the how to use carbetocin. Generally, at standard dose carbetocin, 100 microgram IV bolus we prefer. Next. And I'll share my experience where how I use carbetocin. Now I am sharing the three cases here. First will be our normal delivery. That is a normal labor when we patient underwent a normal non-high risk patient, direct 26 year, 25 years woman, primary gravida with no any high risk factor. She delivered full term vaginal delivery. What we usually do after the delivery of the baby, we inject 1 ml of carbetocin. At the time of normal delivery, we specially use intramuscular dose. And at the time of C-section, we use the bolus dose. And there will be uneventful placental delivery, no PPH, and there is no any additional uterotonics like methargine or pitocin. Next. So next scenario will be in the cases of C-section. What we do in the cesarean section, this case was like a second gravida, para 1 living one with a previous LACS. She presented at 38 weeks with polyhydramnios and also in the labor pains. And she also has a scar tenderness. She was immediately taken for C-section. Her HB was 10.2, so little she was a mild dynamic also. So we reserve one PCV. As we are appreciating, there will be sometimes scar tenderness is there, so rupture might happen. So we are taken for LACS. There was evidence of thin lower segment scar after opening the abdomen. Immediately after delivery of the baby, we injected the carbetocin slow bolus, and the uterus was well contracted till we sutured the everything. Uterine closure was done, abdominal closure was done, uterus contracted well. And also in such cases, sometimes we keep the prophylactic misoprost per rectal, so it will be have additional benefit. Next. Now, the third case scenario is important. We recently managed the case. She was a 35 years elderly primary gravida, history of infertility also. She was having severe preeclampsia. Also, she presented with a PV bleeding. Our clinical suspicion was abruptio placentae, and also on admission, her BP was 160, 100. Albumin urea was there, 4 plus albumin. We did elliptic AFT coagulation. It was in the normal limit at that time. And so bedside ultrasound was done. It's showing a retroplacental clot. So the clinical and ultrasound picture was suggestive of abruption. So we have immediately taken for LACS. We delivered the baby is around 2.2 kg. And immediate after delivery of the baby, we injected the carbetocin. And also in this case, we kept the misoprost also per rectal simultaneously. So with this, uterus contracted well, there is no additional PPH, and mother and baby both were fine. So this was the high risk pregnancy, and we still are using in cases of preeclampsia, eclampsia, abruption, where the chances of atonic uterus is more. That is good in cases of this. This is useful. Next.
Thank you so much, doctor. It was interesting. One thing was interesting, what I saw is that in most of these complicated cases, you're using misoprostol along with carbetocin, just
Yeah.
not to take any risk.
Yes.
Overall, what is your experience with carbetocin overall? You
Yeah,
have been using it for past 2
since
years?
last 2.5 years, we are using this carbetocin molecules. We almost 50 to 60% we have replaced the oxytocin. So we are happy with the molecule, but sometimes, yes, I'm not sure about that, but around out of 10, there will be 2 patients may have a little bit bleeding.
Correct.
In that case, we have to use extra additional
Absolutely,
uterotonics.
absolutely,
That is
absolutely.
fine. We can see comparative with the oxytocin. It is also good choice, and also it is easily usable by sisters. So we are
Yes.
happy with that.
It's a textbook brand finally.
Text, yes, yes.
Yeah. Which patient profile can we expect PPH?
See, as we know, as in obstetric, there are any patient can land up in
Yes,
PPH.
yes.
There is no any, but as a doctor, as an obstetrician, we label some few patient as a high risk. That
High
is,
risk.
yeah, that is the first and foremost is when patient is elderly patient, when there will be a multiple pregnancies like twins, triplets, abruption patient. Then there is a hypertensive, that is PIH, preeclampsia, severe anemic patient. This patient, most of the time, they'll end up in the PPH. And also sometimes multigravida patient also. When there is a parities, para 3, 4, para 4, then these are the complicated patient and they will label them as a high risk. These are prone for the PPH. Yes.
Now, you use both carbetocin and oxytocin, but where you would prefer carbetocin over oxytocin?
Yeah, already I have already mentioned it.
Yes.
Now, since last 2 years, we have started using carbetocin
More
in the high
commonly.
risk group only. Yeah, especially in the high risk like PIH patient. Even in the cases of eclampsia, also we have used carbetocin. Even twins cases, we are preferably using carbetocin. So any high risk group, already what we discussed in last question, our choice will be carbetocin first. If it is not controlled by carbetocin, then we can add other uterotonics. Yes.
Can you use carbetocin in case of retained placenta?
Yes, of course, we can use carbetocin in cases of retained placenta. There is no harm. As we use pitocin in cases of retained placenta, we can use a carbetocin also.
Carbetocin. You have had any occasion to use? I would not use the word occasion. Any condition, any patient?
No, I have not. Means my personal experience is not there with the retained placenta, but there is no any harm in using
Contraindication.
contraindication.
And in RH negative mothers, because this
Of
could
course,
be
we can.
important. Yes.
Yeah, we can use in the
There is
RH
no
negative mother. There is no, because while we are using oxytocin, same we can use carbetocin also. There is no any contraindication.
Now, can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction? Most of us use oxytocin for labor induction.
Yes, yes.
So,
This is the
yes,
most important thing.
yes,
We can use carbetocin. Yes, as we know, the oxytocin half-life is very short.
okay,
So when patient delivers and patient is already placenta and all the everything is out, we can add the carbetocin for the prevention of PPH. There is no harm as oxytocin is a small half-life. It will degrade in the it
in
is
the meantime.
first metabolism is that time it will be vanish and the carbetocin will act next.
Okay. So there's no harm in using.
No, there is no any harm.
Now, you have been using both IM and IV. You said that in normal delivery you use
Yes, yes, yes.
IM and in high risk you use IV.
IV.
But otherwise, I mean, what is the preferred route of administration? I
Most
suppose
of the
of
time we use IV only.
IV
But
only.
yes. Only in the cases of normal delivery,
Yes, yes.
because at the time of C-section there will be anesthetic in the OT. If
Absolutely. Yes.
anything happens, they will take care of that part because any bolus injection we take more precautions. So
Correct.
IM route at the time of normal delivery, as there are the sisters and we doing
Correct.
it. So we prefer both the routes, but IV is more potent and also we saw result good with IV routes. Yes.
So what is your opinion about a pre-filled syringe of carbetocin?
It will be a very good means it is a very important and it's staff and everything will be very happy if you
Absolutely.
prefer yes because when there is a delay happens we have to rupture we have to open the vial everything will happen
Absolutely.
when there is a ready-made syringe is there then it will be a
And
little
correct,
useful. Yes,
correct dose will come.
correct
Apple
dose will
मधून
be coming.
apple
Yes,
मधून घेताना पिताना, it can happen.
yes. So prefer is that.
Yeah. If patient is not responding to adequately or sometimes has more to be
Hmm.
more careful, what additional uterus in your case it's clearly misoprostol that we have seen
Yeah.
that you have been
When there
preferring.
is no response or there is a less response with
Like you
carbetocin,
said, yes,
then we preferably add a carboprost or the prostolin
misoprostol.
injection. Yes,
Yeah.
and then third will be our misoprost is almost routine for almost every case for the C-section.
Okay.
But after carbetocin, the choice will be a
Carboprost.
carbetocin carboprost, and if patient is there is no contraindication for methargine or methyl argometrin, then we prefer methyl argometrin also.
Like suppose if the patient is asthmatic where we cannot use carboprost, we have to
When
go
there
to
is a severe,
methargine.
yes,
Yes,
in that case, there will be carboprost. Then
yes,
otherwise, methargine also
methargine.
having
Yes.
good use.
Correct. Advantage of oxytocin, misoprostol, carboprost, or methyl argometrin.
Yeah, as already compared the carbetocin with oxytocin, it is easy to use, it is heat stable. So always when we keep the oxytocin in the refrigerator only, then their potency will be good. Otherwise, if we keep the oxytocin in the room temperature, they will lose the potency. Otherwise, oxytocin is comparable with the carbetocin. Misoprostol, as we know, there are little side effect,
Yeah.
and it is not a sole molecule we can use in the PPH or in the control of third stage management. So there will be having gastritis, patient will end up in shivering, everything. So there is a little bit side effect. Carboprost also same things happens. There will be cramping pain. There will be a bowel and a little bit disturbance will be there. So carboprost causes severe nausea, vomiting also. So there are the precautions with carboprost. And as we know, methyl argometrin is we have to use a little bit specific in few cases where there is no hypertension, there is a asthma. And in that cases, we have to use a molecule only, except methargine.
And one of the greatest advantage over oxytocin is we don't require a cold chain because the power,
Yes,
outage is a problem even in Mumbai today. And we
yes.
don't require a single injection is anytime preferable to the drip.
Of course,
And
yes.
sir, have you seen the side effect of ADH problem with oxytocin?
Sorry?
ADH, water retention with oxytocin.
With oxytocin we have seen many times. Not in
Okay.
the recently, but in the when we were in the student in the residency,
Yes.
we have
Yes.
seen this retention of the water retention with oxytocin. Yes.
And then we have to give Lasix, fluidate, etc.,
Yes.
etc.
We have to use multiple modalities. We have to push
Yes.
the patient and we have to restrict the water, so even intake
Correct.
also.
Should carbetocin be kept as a reserve drug or it should be used as a first line?
Almost at the right
First
now
line,
we
yeah.
are using the first line.
First line only. Yeah,
Yes,
that's
yes, of
correct.
course it should be first line nowadays.
And when best is available, why wait for
Yes, yes, yes. Yeah, of course we have seen the advantages of it.
correct. And adverse effect I mean advantage of this we have already seen.
Hmm.
Last thing is, what is your one-liner on take-home message for Carbetocin use?
At current scenario, at present, it is one of the best molecule to use in either in the normal third stage of labor or also in cases of PPH. So carbetocin will be the first choice as a uterotonic.
Well, thank you so much, doctor. Your insights are definitely useful. More than the theory, it is the doctor's insights which help us. And I'm sure the audience would have benefited out of it. Thank you
Thank
so
you.
much for taking time. Thanks
Thank you.
all the
Thank you.
participating doctors who took time from their busy schedule and attended this. Thank you, marketing team Heathrow, for conceptualizing. Thanks, field team Heathrow, for making it possible. Last but not the least, thank you, Jayant, your IT team, for backup support for IT support. Thanks all of you. Signing off. Thank you, sir. You can log off, sir.
Thank you, Vetro and everyone.